I am going to do a little spiel and then we are going to get to it. I want to thank you guys for being here. I want you to invite more people if they want to learn, and let's get started. Someone's doing my slides. Oh yeah, I'm supposed to remind everyone if you want to talk, and I want you to talk. So, I mean, you have to ask for permission. I don't know. We're going to have to think about this. So here's our agenda. I'm going to do my spiel. You're going to love it. Then we're going to get to the real heart of this. We are so lucky to have Mike Taylor here, also not a robot. And Mike Taylor has been working with MiHIN for, I don't know how many, like 27 years, Mike, like how many years?
It'll be 10 in a week.
Right. So in health information exchange years, that is 700 years. So he knows a lot. He can explain it. He's gracious and generous with his time and knowledge, and we are very lucky to have him. But he comes after me, so let's go. Next slide. What's MiHIN? Things you should know. MiHIN is a nonprofit organization that sits between many powerful sectors to connect them securely, legally, and for the purposes of helping people to be healthy and well. We are an unbiased data trustee. We don't produce any healthcare data. We are to be trusted with it. We are a neutral party. And really, we help to convene to share vital information to advanced care, to better outcomes, to lower cost, to create maybe more precision medicine, to for the better of the public. And we convene, so we actually convene like this, and we convene technologically, right? And both of those things are really valuable, sociological and technological. Don't forget that we're humans, guys. All right, let's go. Next slide. This is how I am choosing to work through these convenings. And if you hate it, let me know. But basically, I like to start with a why. I feel like if people don't have the why in mind, it doesn't matter how or what. I know you want to get to the what. I know you want to get to the how. And if you want to get to the what or how, and you want to dive in deep, you'll have to come back for our bits and bites where we dive in technically how and what of ADTs. Today, you are at the download, and we are doing the why and the who. I hope you have been here for our MiHIN 101s. I hope you have been here for our Use Case Factory 101s, or perhaps our advanced care planning workshops. Maybe you were here when we elevated our social care vendors to talk about why it was important for them to move interoperably into this space, just as healthcare is now deciding to do. Next slide, please. Why MiHIN? MiHIN, the idea of a health information exchange, a central router, a central data steward, is that not everybody has to connect to everybody else all the time. Connect once to get to everybody else. Next slide. We are a data steward, which means that we must act to protect, to collaborate, and to protect, to act, and to collaborate. Our goals are to reduce inefficiencies. Our goals are to improve healthcare access and outcomes at lower costs. And more getting clearer about what information is needed to take better care of people. And how do you get it? And who's legally allowed to get it? Next slide, please. Who do we do this for? Well, we're trying to work with so many people. We're really trying to make so many different entities, disparate organizations, powerful actors connected and happy and working well together. We share data. We work to share data with the federal government, the state government, health departments, health payers, health systems, PIHPs. Of course, we move down to through hospitals, through clinics, through CMHs, through hospices. You can read. Look, we're moving through all these people. We're moving up and down, right? To doctors, to nurses, to clinicians, and more, I can't wait for this, to actual care seekers, to actual human beings who will decide how they want to use their information. It's going to be fabulous. We do this at scale, folks. We have about 44,000 Michigan care providers that have active care relationships, which means that they're actively caring for people in Michigan, and we know who they're caring for. There are over 5,500 care entities connected. We have 13 million unique patient records. We're trying to do this at scale. We're doing it statewide. Next slide, please. Oh my God, this is the best part. So I am going to introduce, like I said, Michael Taylor, and he's really going to dig in here. I want to encourage you to come off mute. I want to encourage you to engage, write me in the chat, tell me everything. If you want to write me privately, and then I'll ask, let's just get this going. What is an ADT? Why are we here? Why is this important? Michael Taylor, our product marketing manager, and like I said, a real MiHIN veteran. Take us through this, please. And thank you.
Thanks, Joanne. So to get started, an ADT is short for admission, discharge, and transfer notification. An ADT is a health level 7 or HL7 standard. HL7 is a standards creating organization that governs over several different types of standards. We're not going to be getting into looking at what an ADT actually looks like today, but if you join us next week for Bits and Bytes, we're actually going to open up an ADT and say let's look at the data in here and what we can learn about the structure of an ADT. But you should know that an ADT generally is used to communicate a patient's status at a given point in time. And that's important because there are documents out there. Most of us are familiar with a CCD or a continuity of care document that's going to have a whole bunch of points in time that will tell a story that says the patient was admitted this time, this happened, we did this service, blah, 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 blah. And it will have a series of events. An ADT is saying the patient was admitted, and it has information that's true as of this moment that may not be true at the next event. So it's a series of updates that are going on. Go back real quick. It is traditionally associated with hospitals, but that is not a rule. We'll take a look at that in a little bit. And they really are generated anywhere that EHR technology is used. So now we can go to the next slide. So an ADT can come from anywhere. It is traditionally associated with hospitals, but anyone who's using an EHR may generate that. Obviously, the term admit or admission typically is associated with an inpatient encounter, but there are other message types associated with ADTs. In fact, there's a whole slew of message types, like a patient registration message that may be applicable to an outpatient setting where health clinics might be registering patients in their EHR, and they'll be notifying, they'll be able to send an ADT out as a result of that. Next slide. So like I said, there's a whole bunch of different message types, and you can see on screen that there's just a mess of them. I don't think anybody could name all of them off. There's probably like 8 of these that I know off the top of my head, and the rest I have to reference a chart for. But if we click once, we'll see that the AO1, AO2, and AO3 up there, they're all numbered numerically starting with an A. We see the admit, transfer, and discharge up there. And if you click again, it just zooms in. That's really the crux when you're talking about admit, discharge, transfer. That's what people mostly want to know is, oh my gosh, my patient has been admitted, they're transferred somewhere and I need to know where, or they've been discharged and they're ready for care coordination outside of that setting. So when we're talking about ADTs, those are what people from a business standpoint care about the most. So why do we have all these other message types? It's important to make sure we have this information because if we look back at this and there was one of these message types that was updating a patient ID. So if I sent one message that had an encounter information and it had a patient with a certain ID, and I sent another one later and the patient ID was different and I didn't communicate directly, just to let you know we had the wrong patient ID and we're updating it, that might be really hard to figure out what they're trying to communicate. We don't know why there's 2 different patient IDs and now we've caused problems. But when you actually have a message to say, we're updating that patient ID from that last message we sent you, then the receiving system knows how to interpret those types of things. Let's go ahead and go to the next slide. So what types of information do we see inside of an ADT? We've got information like, where did the message come from? It's also going to tell you who the providers are that we're actually working in this particular event. It's going to tell us the time that the message was generated, what this message is, like on the last slide, all of those different event types are communicated in the message. We need to know who the patient is, obviously, and we also have to have enough information about the patient so that if we have two disparate systems that don't use the same patient ID, we can still know whom we're talking about. We need to know who's helping the patient. I already mentioned that. Is the patient still alive? That seems like a really no-brainer thing, but that could be really important if when we have people going to hospital emergency rooms that may not make it. That's an important message to communicate out to the primary care providers that the patient status is no longer living. It'll also communicate what observations have been made, what diagnoses have been made. Does the patient have insurance, and other information about what's happening right now. Let's go to the next.
That
slide.
very moment in time.
At that moment in time. So now that we know what the overall kind of idea of an ADT is, why do we care about them? Next slide. So first up, I'm going to take a look at a total happy path. This is the dream scenario ADT. This is not going to be every single patient encounter, but let's imagine a scenario where I get admitted to a hospital, and while I'm there, I have a procedure done, and when I'm discharged, that infection, for whatever reason, gets infected. For an average person, I'm not going to immediately call the doctor and go get on antibiotics. I don't even, a lot of people don't even know what the initial signs of infection look like. It's probably going to grow and get worse. And then I would show up back at the emergency room saying, oh, I can't, whatever this infection is needs to be taken care of. In a world where we have ADT notifications going around to care managers and primary care physicians, we can have a follow-up visit. And the reason that follow-up visit can happen is because the primary care physician knows that this patient of mine went to the hospital and they've been discharged. So I can schedule a follow-up visit. They'll come, and while we're doing follow-up care, I can look at that site where the procedure was performed and say, "Ooh, that looks infected. We should get you on antibiotics." And that visit that's going to be inconsequential financially overall could prevent a tens of thousands or even hundreds of thousands of dollars readmission to the hospital, where the patient would have to stay and they have to make sure that everything gets better while they're under the care of those physicians. There's other benefits in that scenario. So in this scenario, not only did the patient get better care, the outcomes improved, but also, and the costs were prevented, but also the provider had a billable event, right? Every major insurance in Michigan is going to cover a follow-up visit from an inpatient encounter. And that follow-up visit is a billable event to the provider, where they can now spend focused time on the population of patients they have, instead of having to increase that population size to have more billable events. So that's just one scenario. There are a whole bunch of clinical scenarios where ADTs come into play over and over, way more than we're going to be able to get into today. But that's just one example where there's everybody wins when we have care coordination of patients from an inpatient setting to an outpatient setting. Next slide. It also benefits public health reporting. I'm going to go into the chat and take a look at what's been being said after I get to the next two slides. I know keep seeing things pop up, but let's get through these two slides. So actionable data for public health. The Michigan Department of Health and Human Services is able now today to monitor drug-related poisoning that happened in hospital admissions through a dashboard that's created that they can monitor for those types of events as a way. It's one tool in their belt to be able to handle the opioid crisis, and a known thing that there is a massive thing going on in our ecosystem where people are having opioid overdoses, and we can look for trends. We can see, oh my gosh, in this particular region of the state, there is a huge surge, and we probably need to go investigate that more. Next slide. And benefits for benefits of ADTs for payers. Just like I described in the Happy Path scenario, there are cases where there's not a primary care physician in the mix necessarily, or maybe there's not a care manager from that office monitoring the ADTs, but payers have a real financial incentive to try to manage the care of a patient as optimally as possible. And so they can have care managers monitoring ADT feeds for their patient population. When they do that, they can make sure that the care gets transitioned from that inpatient setting to the outpatient setting. They can consult with the patients if they're going into the inpatient setting, using it as their primary care. If you're just waiting until something's wrong and showing up in the emergency room instead of scheduling a regular appointment with your primary care physician that could have prevented that hospital admission, that's something you can talk to the patient about, and that in many cases, they'll be able to reduce the not even just readmissions, just prevent admissions to the hospital that way. All right, let's take a look at what's been going on in the chat. Sorry that I'm not good at.
To apologize. We've been doing it. We've been backing you up. Diane Marriott asked for an example of a primary care, ADTs coming from primary care practices. And Katie kind of came back and said that an ADT was sent when a patient presents with their specialist. But what about for, like, do primary care physicians send admit, discharge, transfer notifications?
I can answer that one, Mike.
Go ahead.
We do have primary care and some specialists in our practices that are submitting ADTs that do submit at a minimum AO4 registration messages, and they do usually follow them up with a AO3 discharge at the end. There might be a couple of AO8s in there, but mostly it's a AO4 and an AO3, which is the registration, and the other one is the discharge. And it contains the normal information that we require for the hospitals.
Thanks. That's perfect. I know that we have a lot of different health systems that have been sending outpatient ADTs from primary care. I remember myself specifically, because we mentioned I've been here for 10 years, I think it was 2014, maybe it was 2015, onboarding Michigan Medicine. And I remember at the time, they had more senders than anyone else, because they were the first people we were onboarding who were sending their outpatient ADTs to MiHIN. So that's when I remember off the top of my head. So why are ADTs so complicated? HL7 already gave us this standard, right? HL7 said, here, you send this message around. What makes them so complicated? Well, we need to understand the difference between semantic and syntactic or structural interoperability first. So semantics is the meaning and syntactic is the structure. And the HL7 message standard really gave us the structure. They tell us, put the patient's name here, put address here, put this here, and we know where to put things. But in many cases, the specification does not get into real detailed value sets. So when we first turned ADTs on, some people were sending us values here. I have the example of male. Some people would send the letter M instead of male, and some would use O1 and O2. And they knew what that meant within their own system, but once we started exchanging statewide, all of a sudden we had this semantic problem of not being able to understand each other, even though we were saying this is the patient's gender. Another example is NA in a ethnicity type column or type field can mean Native American, and it can mean not applicable. And there's no way of knowing which one you mean if we don't have some sort of standard to point to. We're going to talk about how MiHIN has used conformance to try to drive that a little bit, but understand that just because we have a place to put the data, it's kind of like having a paper form with blank places for you to write data in. And until we say you have to use these values in those fields, then there's still a lot of questions about interoperability there. The next reason that ADTs get complicated is that we need to have context when you get an alert. If we just said, a patient's been admitted and here's the patient ID, and even if we had a universal patient ID and everyone knew who that was, there's still a lot of information you need to go. Where were they admitted, right? That's the things pile up really quickly. Like I was pointing out earlier about, is the patient still alive? That's something you really want to know in an event notification when you're getting this type of information. And so the list just keeps growing of data until it gets big enough that it's complicated. But it's really critical to communicate that information so that people aren't making incorrect decisions based off of the notifications they're getting.
And Mike, don't want to interrupt you, but I do see that Dan has his hand raised. So just want to make sure if we don't get too far ahead before he's able to ask this question.
Sure.
Michael, I just wanted to point out too that we have the OBX segments in the ADT messages are another area where people note information about their patient visit. There may be a questionnaire in there about different things. They put in vitals in there. They put in observations about social determinants of health, different things like that. So that's another area that you might want to include with where the conformance happens, where data is placed, where we need to look for specific pieces of very valuable information per encounter.
Exactly. Yeah. Great points. The more you drill into ADTs, the more you can find complexity everywhere, all over. The next point is, on top of all that, on top of the semantics and the structure, HL7 gave us a definition for how to compose the message, but they never said when. And so there are different workflows we see in different hospitals and health systems around the state and around the country. An example is that sometimes a patient comes in and you don't know you're going to admit them. They get an AO4 registration and they're going through an evaluation at the hospital. And eventually at some point in their encounter, it's decided to admit them. But instead of sending an AO1 at that point, because the patient's already been registered, they send a patient information update, an AO8, and the patient status will be changed from outpatient to inpatient all of a sudden. And that adds complexity to receivers to understand these scenarios, so we can try to figure out, okay, this patient is actually admitted to the hospital now. They're actually admitted to an inpatient setting, even though they weren't in any previous things, and I didn't get an admit notification. So that workflow scenario adds complexity as well. Let's go to the next slide. So why do we need a statewide solution on ADTs? Now, here's where we're finally going to get back to the hospital or origination of ADTs. Next slide. So historically, ADTs were about communicating between different systems in a hospital. There wasn't a common electronic health record, and that's still not the case in many hospitals by choice or by just it may be an intentional decision that each department has its own system. But even if you're using one common system like Epic, you're still going to have departmental implementations. And so they had these messages so that from the registration system, they could send to their emergency department a message saying this patient's coming, and they'll have all the information when they get there. That's where ADTs really came from, which is why we associate ADTs with hospitals more than outpatient settings. Now, as the ADT standard has become better understood, people started to say, hey, we could use ADTs for other purposes. And let's go to the next slide. So instead of just sending between departments in the hospital, maybe we can take the exact same message using the exact same standards that the EHR knows how to produce and send those to the relevant specialists, primary care physicians, care managers, and the payers whom have a relationship with this patient. And it can also have meaning for them for scenarios like the coordinating the care from an outpatient setting or from an inpatient setting to an outpatient setting, back to that primary care physician, back to the care manager that the patient has worked with before. That type of information, or that type of flow, started to become an awareness thing. Next slide. So people started building interfaces before HIEs existed, and different doctors' offices and different physician organizations and groups would be able to get access to the ADT feeds. But the point-to-point system in that scenario gets really, really unwieldy. You've got a lot of hospitals making a lot of connections to a lot of different places. So let's go to the next slide. So it really makes sense to have a central connection point. And when without even putting the MiHIN name in the middle of that, when you start talking about a central connection point, that really looks like MiHIN's model that Joanne was going through at the beginning, right? Where instead of having a million point-to-point connections, let's have everybody connect to the central thing once, and we can route between them. All right. What does MiHIN do with ADTs, and where do they go? Yes. So now we're going to get into an actual example of message flow. I think that was requested earlier. Next slide. All right. So in this scenario, we've got our persona patient, Tricia Franklin. Tricia Franklin goes to the hospital, and an ADT notification is sent out from the hospital to here. They say trusted data sharing organization. That's a fancy word for somebody who's connected to MiHIN, like a health information exchange. Let's use Dan Boyle as the example here. And we've got the Upper Peninsula Health Information Exchange gets that ADT and sends it to MiHIN. So at that point, MiHIN is going to take the ADT, grab just the patient who's listed in the ADT, and we're going to go to our active care relationship service. And if you're unfamiliar with the active care relationship service, sometimes we'll call it ACRES, is
We'll
really
do a
just...
download. It's coming up.
Excellent. But in a nutshell, the active care relationship service is it's a patient panel. It's people saying, these are the patients whom I have a relationship with. I expect to see them again, and I have a treatment, payment, or operation relationship with them. So we take the patient information from the ADT and say, who has a relationship with this patient? Who cares about this patient? And we get a list back from our active care relationship service. Then we go to our health directory and we say, all right, where do they want to get this information sent? And we'll look up each of those organizations or individuals who have a relationship with this patient and look up what different digital endpoints, how MiHIN can deliver the message the way that they want. And there's different ways that you can receive ADTs from MiHIN. We have toted in the past that we are agnostic to the method of how you send us or want to receive an ADT, and we'll try to support as many different standards as possible for that. So once we actually have the delivery information, we then can go back to the system that has that ADT and is still waiting and we say, deliver that message to these locations, and that'll be sent out. It'll be received by the trusted data sharing organizations that are connected directly to MiHIN, whom then have their members subsequently that can be notified with the ADT. I'm open for questions now. I just looked at the chat and I saw how often is the ACRES file updated. So there's several different answers. The expectation is that it is at least monthly, but can be more often. And there is a service that MiHIN offers in certain cases called real-time ACRES, real-time active care relationship service, where we can actually generate active care relationships instead of using a file that you give us, using something like an ADT feed. And so if a patient's sending ADTs to MiHIN, we know that a patient that was admitted there, they had a relationship with, and they may be interested if the patient is readmitted in the next 30 days or whatever the interest is there. And so we can create a relationship in real time so that we can send them back a notification if that patient is readmitted somewhere else. So that's how often ACRES are updated, is between real time and monthly. Yep. Any other questions at this point? The active care relationship service is not a string of ADT files. It is just nothing more than a relationship between a patient and who cares about them. It may be a provider, it may be a practice, it may be a physician organization, it may be a payer, somebody who has a relationship with that patient, and it's just really, really, really big database of those relationships. Is ACRES allowed for mental health organizations, as the ADT may contain psychiatric info? That is a good question. Okay, so we've been working for a number of years on what we call e-consent, and we have an electronic consent management service specific to 42 CFR Part 2 data. That is 42 CFR Part 2 is the federal legislation that defined what specially protected information was. And that would be from facilities that are federally funded, that primarily do behavioral health, or I think it's substance use. But anyway, for 42 CFR, we have a consent management service that can hold consent that's on file for who can receive data for a certain patient. And for ADTs that we get in from those facilities, from a 42 CFR Part 2 qualifying facility, they'll have privacy tags on the ADT that says, this ADT contains specially protected information. At that point, MiHIN says, okay, we know this is specially protected. Let's go not only to the active care relationship service to see who has relationships, but also check this consent database to make sure we're allowed to send it to them. That is something we've been working for a long time, and as of the end of last year, we had just finished piloting it, and I apologize, I'm not positive if that's in production or not. Yeah.
Mike, I think this might be a bits and bytes question. There's one from Lindsay, and she's talking about ADT files not being easy to work with. And like, I feel like when I learned, and as I learn more and more about these ADTs, I can see how they would be hard to work with.
Yep.
Can MiHIN, are we going to talk during Bits and Bytes about what MiHIN can do to help?
Yes, at Bits and Bytes, we're gonna, like I said, we're gonna take a look at the message structure, but then we're also gonna talk about some different strategies for how ADTs can be utilized, both from a business standpoint, but then also from a technical standpoint of, how do we deal with these unwieldy things? From a business perspective, just to communicate to other people some ideas of what that question is getting at, imagine that you don't have a system that's collecting all, one encounter is going to generate many ADTs, right? Just when you're admitted, discharged to another department and transferred, we know there's 3, but then there's a lot of patient information updates that can go in. I have on the metric slide an average how many event notifications we see per encounter. I don't remember what that is, but we'll get there. But if you don't have something that's collecting all those into one encounter record, it can be really difficult to get 20 messages and try to figure out what I need to know from them about this patient, because it's hard using your eyes to figure out what updated over time.
But more bits and bytes. I'm such
Yeah.
I'm such a pusher. Okay, sorry, keep going.
All right, let's go to the next slide. So what does our network look like? I think this might be where we get to the metrics. Hey. All right. So currently in our health directory, we have, oh no, this is sending sites, sorry. We currently have 1,400 sending sites. And so when I say, including 172 sending hospitals, obviously the vast majority of those are those outpatient settings where ADTs can be generated other than hospitals. So we have a lot of sites sending outpatient ADTs. And we want more. Now in our health directory, we have 8,209 different organizations, meaning practices, hospitals, payers, POs, all those things in the list. 8,209 of them who have destinations for ADTs, meaning they're participating in the ADT process and receiving ADTs. Here's the, there's an average of 44 ADTs per licensed bed per hospital, or per day, sorry, not broad. So that is a lot of ADTs. You can imagine trying to piece together after the fact, if you're receiving these ADTs without an IT system that is designed to put them together. Then we have 7 million ADTs that we're receiving per week. You know, that all of these numbers vary, but on average, we're getting around 7 million ADTs a week for Michigan. But then because of the active care relationship service, we typically have more places to send, we have more than one place to send an average ADT. So it might be a payer and a primary care physician, or it might be a primary care physician and a care manager somewhere. But on average, there's more than one. So even though we got 7 million per week inbound, we typically have about 12 million outbound. All right, let's go to the next slide. Conformance. All right, so conformance is a really intentional strategy that MiHIN has been utilizing for the entirety of my career here. I think for the entirety of MiHIN's existence. The idea is that we're going to pick and choose when we have the structural and semantic interoperability that I talked about earlier. We have to find ways to address that, but we can't just ask everyone to change everything about the way they do things at once. And so we picked the most important data elements to have standardized, and we said, we expect you to send information that conforms to these values. Or in some cases, we said, or you need to provide a mapping table to us of what you are sending and what they mean to our values, so that MiHIN could do that mapping for you. And let's go to the next slide. This is a real world example of a conformance report. The fields have been removed, but this is from ADTs. And what's on the left was how well someone's message conformed to MiHIN's ADT specification before conformance. And what's on the right is how they conformed after we did this conformance. Let me get into why that actually happened. So we partnered with Blue Cross Blue Shield of Michigan. They incentivized people to meet certain conformance metrics. And that's what these fields were all indicating here. From top to bottom, they were different fields that we felt highly important. And Blue Cross Blue Shield said, not only do you need to send ADTs, but you need to get your data to conform at least a certain % of the time to MiHIN specification. And through that process, they're able to earn some money from Blue Cross Blue Shield and their incentives, and we benefit the whole network by improving the data quality. And you can see we were able to significantly move the needle. Actually, now that I'm looking at this, I realize each row was a hospital, not a field. And this was looking at 3 different fields. So overall, for these 3 fields, look at how many hospitals improved the data they were sending. Yeah. Questions? What's happening in the chat?
Thanks, Robert. This is in the weeds here. Happy to take this to our conformance task force. If you don't know what that is, I'm happy to tell you about that. We're also going to get, like I said, really technical, you technical peeps at our bits and bytes. If you are just hearing about this for the first time, or if you feel like you're more of a high-level learner, that's okay. Join the club. And also I wanted to invite, well, what are the slides that are left? Because I know that Katie here has a couple of great ideas about how people can be leveraging ADTs in different, really bold ways.
Thank you, Joanne. So I'll pipe up here very quickly. Mike, thank you very much for talking through really, what these are. Why are they important? So I think really when we talk about how can they be used, we want to talk about a few different ways that you may not have thought about so far, and maybe you have, and that's great. And we also want to solicit other ideas from some of you folks who have been in the weeds about other ways that folks could use this more, could take this data and start to actually develop additional insights and additional information. So some of the other ideas that we've talked about and seen used very explicitly are care coordination, right? That's obviously top of mind for a lot of folks. And really looking at, patient is discharged, AO3 comes through. How do I prioritize all my discharges that came in over the weekend? I know for a fact, right, I need to reach out to every one of them if I'm the nurse sitting within that PCP practice. But if I have somebody who had an AMI, how do I reach out to them and say, oh my goodness, they had an AMI, they've been discharged. They've never had another cardiac event. I need to get them in touch with a cardiologist. I need to make sure that they have that appropriate level of care for follow-up and actually be able to coordinate back and forth with that other care team member to make sure that they have the most effective care. We also touched on readmissions, which we all know is such an impactful measure and such an impactful thing for patients overarchingly. Not to mention, obviously, the monetary implications from a lot of the health systems and or health organizations that are seeing that from a payer perspective. As we look at trying to actually figure out where are our patients going, almost like a GPS for patients. Where are they going? Where are they seeking care? What types of care do they need? This has been very, very influential as we start actually looking at getting this information in real time and being able to actually say, hey, this patient was seen yesterday. How do I follow back up with them to address their need, even though they were seen in the ER, or even though they did come back for one readmission? We don't want to. Additional ideas. We've seen certain organizations utilize this information for disease registry follow-ups. Oncology definitely being a top of mind for one of our very large health systems that has made this thoroughly successful within the state. They're actually taking these ADTs, putting them within their oncology registry and saying, this is how we make sure we follow up with every patient who actually had a biopsy that was malignant in our site, and we have to follow up with them forever. How do we do that with these ADTs instead of us trying to do onesie twosie connections, getting access to charts really across the state? Additional ideas. How do we potentially look at this for patients that, you know, if they belong to a specific risk-based contract or an APM or something to that effect? How do we actually start saying, why are they using the ER as their PCP office, right? They're technically attributed to our office. Why do they continue to go there? How do we reach out to them more proactively? How do we potentially identify members of this patient's care team so that we can more effectively coordinate with them from a patient-centric perspective? How do we potentially tap into that utilizing our active care relationship service? And there's a multitude of ways to do that from a technological perspective, whether that is an API or a report or something like that. As we start talking about some of these things, we want you to bring us the issues that you're seeing. We want to arm you with the knowledge and the information of what these things are so that you can look at within your specific environment, how could this potentially be used in the most effective and influential way to make these patients more happy, healthy, and truly just more productive in society in totality because of those reasons. So
As a
really,
mom, I really want an ADT like on my kids. Are we working on that? And is that a use case? I will submit, and I'm not even joking. People are always like, if somebody gets lost and everyone's like, oh my God, we got to call the hospitals. Sorry, I don't want to take us down that, but away from healthcare. But gosh, this information seems so important, so elemental and basic to have to take care of people.
absolutely, Joanne. And I'll throw in one more quick comment here. I know that there has been a substantial amount of great conversation in the chat asking about, you know, kind of, what is this? Isn't this just a simple, you know, name and where this patient went, almost like a glorified fax? It's really not. There is so much more detail that is actually embedded within these messages, again, that can be leveraged in a multitude of ways that has not even necessarily been used to its full potential yet. And so I think, as Joanne has said on here multiple times, right, we are going to be doing a bits and bytes session after this as well, not today, but soon. And we're going to be digging into some of those details and showing you the information that is available. So I will stop there. And Joanne, did I cover what you were looking for? Is there additional pieces you were seeking before we go to the questions?
I just want people to know that you're here and that you have, you know, we have a lot of people that work with us, thank God, that like have used ADTs in their clinical practice, running health systems, running hospitals. And we are here for you to be able to access them. Also, Mike, I know I cut you off. We wanted to talk about what we're doing at a national scale and what people are doing at a national scale about ADTs. But I also want to make sure that we are giving people absolutely enough time to get what they need out of this. They've been here for 50 minutes, and let's make sure that we're getting, you know, we're getting everybody what they need. Like, why'd you come? Did you learn it? What else can we tell you? And will it be at the bits and bytes?
Absolutely, not a problem. Yeah, I'll cover this last slide and then we'll see what questions we have to take us home. So MiHIN really covers the state of Michigan, and we're part of Civitas, which is kind of like a national network of HIEs. And Civitas has come up with this idea of a patient-centered data home. And the idea is really totally makes sense when you hear it. So just like a patient-centered medical home, where that place is the point of reference for a patient, and the interactions with the patient find itself back at the patient-centered medical home. The idea of the patient-centered data home is that as patients go to other states, whether they're snowbirds, whether they're on vacation, whether they're traveling for business, whatever it is, if they go to the hospital somewhere else, that information can make its way back to the home state of that patient and then ultimately to the primary care physician. So the way it's going to work is that there's one central location where the ADTs nationally are sent, and similar but not the same to our active care relationship service, it's going to look at the patient listed in the message and say, but it's going to specifically look at the address of the patient and say, where's this patient from? Let's make sure that gets back to the HIE that's in charge of that region or that state or that territory, whatever it is. We route that ADT to the appropriate health information exchange, and from there they can go through their process. So if you get admitted to one of these states where there's another participating HIE, MiHIN will subsequently get that ADT if Michigan is your home. We'll then go through our active care relationship list and deliver it to our the members who have a relationship. All
We
right.
have these pipes, folks. We've built these pipes. You have invested in these pipes. The state has invested in these pipes. The federal government has invested in Michigan's pipes. Through Michigan's pipes, critical information flows legally, privately, securely. How do you want to use the pipes? Can you use the pipes? That's what we're here to try and help you do. Next slide, please. What data do you want to share? What data do you want to get? Is data information? Let's talk through it. What's it going to be used for? Who are you caring for? Who else is caring for that person? Do they tell you? Want to know? Next slide. There has to be policy. There has to be legality. But if we can figure out a way to do it, we're trying to figure out ways to do it. That's one of the best things about working here. We're always learning and always trying. Look, there's a technical deeper dive. How? What? How to work with MiHIN. What do you need? Let's get into the AO3s and the AO19s and the AO8s. That's for bits and bytes. Please come May 31st, 12 to 1. We have put the registration in the chat. And it is 1:54. What's our next slide? I think it's a thank you. What else? Does anybody have any other burning questions? Do you know how to get in touch with us? And how else can we make this better for you other than giving you back 5 minutes? This recording and the slides will be put on our website. Please share them with the people that you work with that you think need to learn about this. What's the timeline that we can expect for connections? Oh, between states. Do we have a PCDH timeline? I know some of it's been working for a really long time. Hannah, I will take an action item to try and get back to you with more information about that. Okay, as always, thank you for spending your time with us, and I hope you found it valuable. And please keep coming back. And thanks for working with us. And if you're not working with us, why not? Please let's. Thank you, everybody.